I've called it Build Back Fairer because that's the title I gave to my report in December 2020. Let me start, though, with the opening line of my book, The Health Gap, which was why treat people and send them back to the conditions that made them sick. Particularly at the time of a pandemic, we think a great deal about the health care system. I'm concerned with the conditions that make people sick, the social determinants of health. I'll show you this again, but I'll show it to you now for a particular reason. Deprivation, classify people by where they live and classify where they live by the index of multiple deprivation. This is all-cause mortality, and it continues to show the remarkable gradient that we've pointed out over many years. And there's COVID-19 mortality. The gradient's nearly identical to that for all causes at a much lower level. Now, you probably can't read the title of that slide. There's the gradient. So let me give you a bigger title. The gradient in CARIES in 5-year-old children. Wow. That could be COVID-19. It looks identical. COVID-19 is not about a virus. It's about the nature of society. We think, right, it's all going to be fine when we've got the vaccine. Well, then we'll go back to having the inequalities we had before the pandemic, plus the extra inequalities we got because of the societal response to the pandemic. CARIES, as you heard in that video, is related to sugar and lack of fluoride. COVID, we think, is a virus, but the causes of inequalities in COVID-19 and the causes of inequalities in CARIES or edentulousness in older adults are the causes of social inequalities in health. Richard Watt gave me this slide. Alan and I have just been discussing the Marmot review, Fair Society, Healthy Lives, that he commissioned me to do, the government commissioned me to do, and we reported in 2010. We look back 10 years, I think the government should have commissioned this, but in fact, the Health Foundation supported it. What happened in the 10 years since the publication of the Marmot Review, Fair Society, Healthy Lives? My simple summary was, we've lost a decade, and it shows. What happened? Life expectancy, this goes back to 1980, had been increasing about 1 year every 4 years for women and for men. In fact, I could take it back to 1890. For more than 100 years, life expectancy had been increasing about 1 year every 4 years. 2010, there was a break in the curve. The rate of increase slowed dramatically and just about ground to a halt. What happened in 2010? Don't tell me Alan Johnson left government. Yes, he did. But we had a new government elected, Conservative-led coalition government. They said, surely you can't be suggesting it was anything we did that could have led to this slowdown. Maybe we've just reached peak life expectancy. Okay, well, we should look at that. So we looked at annual life expectancy improvement in different countries: Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, Spain, France, Switzerland, UK. We had the slowest improvement in life expectancy of any rich country except Iceland and the United States. No, we had not reached peak life expectancy. Our slowdown in life expectancy was more marked than in any other rich country except Iceland and the United States. I showed you a moment ago deprivation and mortality. This is deprivation and life expectancy. And just to drive home the point that inequalities in health are not only about poverty. The most deprived do have shorter life expectancy. Alan Johnson, in his introduction, talked about the 16-year gap in life expectancy within the Royal Borough of Kensington and Chelsea. But it's not just the poor versus everybody else or the rich. It's a gradient. The less the deprivation, the longer the life expectancy. The gap between the least deprived 10% and most deprived was 9.5 years. As Alan said, you can find smaller areas with much bigger gap than that. For females, it was 7.7 years. And the gap got bigger over the decade. The gradient got steeper. The inequalities got bigger over the decade from 2010. And if we look by region, this is women, look at the least deprived 10%. If you're rich, it doesn't much matter where in the country you live. The regional differences are pretty small, and life expectancy was improving a little bit in every region. If you're in the most deprived 10%, it matters enormously where you live. The regional differences are much bigger. Life expectancy improved for the poorest 10% in London. And remember, this is all pre-pandemic. This was from our report in February 2020. And life expectancy went down for the poorest 10% in every region outside London. And as I said, next week, next Wednesday, we're publishing Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. In the Northwest, life expectancy for the poorest people went down. Now just reflect on this for a moment. Where were we before the pandemic? We've come to expect, based on evidence, that health will continue to get better all the time. That's what's been happening. And over the last decade, that stopped happening. The inequalities got bigger and health for the poorest people got worse. I think of health as a measure of how well we're doing as a society. If health stopped improving, society has stopped improving. If health inequalities have got bigger, inequalities in society have got bigger. And the case I made at the beginning, what I'm saying about health inequalities in general applies to oral health. It shows an identical gradient.
Our National Director for Dental, Sarah Hurley, and I have been in lots of conversations, and I've been talking to PHE as well. And yes, we do have an absolute commitment in this area around oral health inequalities. I know Sarah, as well as Ed Waller, our primary care director, are addressing an all-parliamentary group later on next week on the question of oral health inequalities. So it's very much on our agenda, and not just on our agenda, it's on our agenda with a dedication and commitment to actually doing something about it. As a matter of fact, one of the emails I was responding to before joining this call was very much how we're going to collaborate across NHS with public health colleagues to start to make real inroads in the oral health inequalities space. And as you rightly said, fluoridation, it's in the ICS white paper. You know, there is a commitment there. So we absolutely have a policy hook there that we can build on in this space. And I'll say again, going back to my comments earlier on around, you know, taking a quality improvement approach. So we know that for children aged between 6 and 10 years old, that tooth decay is the most common reason for hospital admission. We know that 47% of 5-year-olds in Rochdale, for example, have tooth decay. Compare that to 13% in Cambridge. And again, if you look at just overall dental decay, most deprived decile of the population, a third of the children have it. You look at the least deprived decile, 12.5%. And we know that water fluoridation reduces the likelihood of getting dental decay in the first place. and the severity of it if you did get it. And so we have the data. You remember I talked about data for improvement. We have the data, and what we're going to do now is to co-produce those solutions. But actually, there's already a solution there, an intervention there in form of fluoridation, and it's about us coalescing our efforts behind that and taking the community with us. So absolute commitment from the NHS.
The purpose of public health is not both adult and children and learning disability social care, and don't forget children and learning disability. The purpose is to create health. That's the sole job of public health professionals, is to create more health than would be there by path of natural default. So the chart on the right, sorry, the chart on the left is the 40-year-old Dahlgren and Whitehead model on the influences on health from age, sex, and genetic makeup, right the way through to general socioeconomic, cultural, and learning, environmental conditions. All of those things and everything within that is within the scope and the field of contemporary public health. And it's absolutely right that public health function at local level is placed in the heart of local government. So my boss is the chief exec of the council, and I'm accountable to, I guess, ultimately the chief medical officer professionally, the chief exec of the council, and the leader of the council. And the scope is all of that stuff. Then there's the locating framework. If you accept the hypothesis that my purpose isn't to address demand problems in health and social care services by better prevention, etc. It's about starting with the things that determine health and working upwards. So my starting point is poor air, poor housing, poor childhoods, and that looks like quite a nice part of green, and that's quite a nice bit of green space. How do we engineer a society and an economy where air quality is better, housing quality is better, etc. You see where I'm going? That fundamentally flips the way that you view evidence, and it fundamentally flips the way that you see the world. So in my world now, the randomized controlled trial, evidence-wise, is not king. And in my world now, actually, political processes are far more important than business cases. The way that people think and the way that people orientate their world is far more important than the business case for X, Y, and Z, because in some of this space, the business case just, it's impossible to write. So for me, the question is, how far upstream do you want to go? So for me, as a public health professional, I'm increasingly getting into the space of poverty and the macroeconomic causes of health and the ideological roots of poverty and economic policy. For dental public health professionals, clearly a long way upstream, a short way upstream is toothbrushing clubs, fluoride varnish, etc. Get further upstream. What about population consumption of sugar? That determines how healthy people's teeth are at population level. And obviously, and I shall come back to this at the end, the F word, as various people have said, that is as close to a silver bullet in this space as we're ever going to get. So, so the question, if you want to be in this space, is yeah, of course you've got to do the basics, but go further upstream, because the answers and the more powerful impacts are always further and further and further upstream. So the point of it, and I'll get onto teeth in just a second, the point of it is the gap. Two charts here. This is Sheffield. Any town in the country can show you a similar gap. This chart on the left, I was never good at left and right, it's healthy life expectancy. So a baby born in Darnall tomorrow, Darnall is here somewhere, yeah, there, can expect to get to about 45 in a state of good health, 45. They can expect to live to about 70. So they're going to have 25 years in a state of poor health before they die. A baby born in Thor, Totley, Fulwood can expect to get to about 70 in a state of good health, and they can expect to live to about 85-ish. You have to ask, is that fair? Is that right? And most of you would say, no, that's not fair and that's not right. That has nothing to do with lifestyle choices. It has to do with social and economic circumstances. No one chooses to become addicted to cigarettes aged 15 to then develop a lifetime addiction to something that will kill them. That's a function of our environment. It's a function of social norms. So, so we need to collectively get over that some of this stuff is about personal responsibility and lifestyle choice. Yes, to an extent, there is some personal responsibility in this, but all of these things, the health outcomes and all of the things that are upstream of health outcomes are largely as a result of social and economic circumstances, as Michael and others have already said. Second chart is the one on the left. This is bespoke data for Sheffield. I've seen it done in lots and lots of other places. It's multimorbidity. So it's more common to have more than one thing wrong with you than one thing wrong with you. And it's more common to have more than one thing wrong with you at an earlier age if you live in the poorest parts of any town than the most affluent parts of any town. So by age 50, somewhere in the order of 30% of the most affluent have multiple morbidities, 45% of the least affluent, most deprived. Or flip that graph the other way around, the onset of multimorbidity is 20 years earlier in Darnall here than Dore here. So when the GPs, and I'm sure the dentists will say the same, I've got lots of frail old ladies with really, my standard response is in the east of the city, there are the same number of frail old ladies, they're just 30 years younger chronologically, and then add to that all of the social complexity. So that's the sort of the field of play for contemporary public health within local government. Teeth exist in mouths. Mouths exist in, and mouths are clearly impacted on by the alcohol we drink, the cigarettes we smoke, and a whole bunch of other stuff. Mouths exist in bodies whose owners sometimes respond to rational cues, but quite often don't. So what are those rational cues? What are the environments in which people live? And what are the things that push people to behave in certain ways and not behave in certain ways? Bodies exist in social systems. So bodies exist in populations and social systems exist in political zeitgeists, so the way in which the government of the day can influence the way that health, term used advisedly, I don't just mean healthcare, but I mean health policy more broadly, operate as a really, really powerful thing. So, so if you kind of want to get into the business of upstream, the business of politics is about as far upstream as I get. And I say that in the company of an ex-Secretary of State for Health. There's always something more potent and equitable further upstream, and all of the influences on health are unequally spread and unequally split. So we all want more prevention, but someone has to give something up to enable that prevention, and therein lies some really, really tricky territory. On the point about accountability and the sort of the shouting, there's some very tricky space around shouting at the government for not having done X, Y, or Z, and there are plenty of things the government have done very well. There are some things that haven't gone so well. There's a very tricky place about shouting versus getting change done from the inside by doing, and that's very tricky. By shouting, you often get kicked out of the room, and then you're not in the room when the big decisions get made. So careful. Sometimes you can shape an influence, sometimes you can't. And for me, the key judgment that every person in my profession, and probably the same in yours, has to make is when to shout, both in public and in private, and when to whisper, and who to whisper to. It's really important. Lastly, never ever underestimate your potency as dental health professionals to be advocates. Now, the story here is I once had the pleasure of hearing Liam Donaldson talk about the, after he was CMO, talk about the smoking in public places legislation, which has saved more lives than I ever will. And it was having some troublesome time in Parliament, presumably under the duress of fierce lobbying from British American Tobacco, etc. Liam did two things. He brought end-stage COPD patients to talk to various people in government. Alan may have been one of them, I don't know. And secondly, he brought jobbing clinicians who treat people with end-stage COPD and lung cancer. And it was a really, really powerful advocacy moment about, so these are the consequences of getting it wrong. So never ever underestimate your power as health professionals to be advocates, because you see stuff that I don't see. I can shout as loud as most people, but I'm not on the clinical coalface. You are. So never underestimate that power. And lastly, be accountable for your actions. So health inequalities is way upstream of oral health But there are plenty of things that you can and must do if you want to redress some of the gap in between best and worst and the haves and haven'ts. And I shall come back to the F word being one of them. I would encourage you to give that a dirty, great big push, because it will need a great big push and it won't happen by magic.
So oral health inequalities are differences in the levels of oral health that are avoidable. And this was something that Michael mentioned at the beginning. They're avoidable and therefore are unfair and unjust in a modern society. They aren't merely the differences between oral health between rich and poor. As is the case for general health, it's about a consistent stepwise relationship across the entire social spectrum, with oral health being worse at each point as you go down through the social hierarchy. Recently in the Lancet series, Perez described also the most marginalized in society experiencing a cliff edge of oral health inequality. And the most marginalized group were referring to those that are homeless, that have disabilities, refugees, and they're experiencing very high levels of disease. So the following slides, a few more slides I'd like to just quickly whiz through, were some that illustrated those inequalities. This first one is by geographic area, showing the difference by regions, with 18% having tooth decay in the southeast. This is the prevalence of tooth decay in 5-year-olds, and 32% in the northwest. But as we go into local authority areas, these inequalities become even greater. I think it's quite shocking to us today in 2019 that 51% of 5-year-olds in Blackburn with Darwin start school with tooth decay. The average for England is 23%, so almost a quarter, but 51% in Blackburn and Darwin. And on average, they will have 3 decayed teeth. This shows us prevalence of dental decay in 5-year-olds by deprivation quintile. So a clear social gradient, those in the most deprived having more than twice as much tooth decay as those in the least deprived. And as I mentioned earlier, the ratio of relative inequality amongst 5-year-olds is increasing. This one looks at service data for hospital tooth extractions. Again, you can see the significant inequalities in admission rates for tooth extraction, with the most deprived having 4 times the rate as those in the least deprived. The trend data, because this shows 3 data points, shows that it has decreased slightly, but that the pattern with respect to deprivation has not changed. All of these slides, I should have said at the introduction, are prior to the COVID pandemic, and we will wait to see the data of what will happen in terms of inequalities post the pandemic, but it is likely to have widened those inequalities. This slide is one that's in press at the moment and has been accepted for publication. And you can see on the slide the same data, the hospital admission rates, but looking at the same period pre-pandemic and post-pandemic. And you can see the dramatic decline as there's limited access to hospital theatres due to COVID, but disproportionately affecting those from the most deprived areas. So what should we do? I think several of our speakers have talked about oral health is part of general health, and we need to focus on how the system can work together. And there's just some examples of elements of the system. So it was really heartening to hear other speakers saying the same thing, particularly from Bola. There's also the importance of place-based approaches. And you can see the publication on this slide from Public Health England that was done jointly with Directors of Public Health and the Local Government Association. And it talks about the best way of ensuring a long life in good health is having a good start in life, a good education, a warm and loving home, and an income sufficient to meet your needs. So simply said, a job, a home, and a friend. These are the things that matter most, and these are embedded in your communities and place. And that's where we have a critical role to play, and that's where we should focus our attention. The same publication talks about the population intervention triangle framework for place-based action. It talks about civic level action, so strategic work, talks about community level action, and service-based interventions. And while I was reading and thinking about this, the population intervention triangle, I thought how closely it matched something that perhaps as oral health specialists, we think more about the upstream downstream model that was described by Richard Watt in 2007. It's one that we're more familiar with, but the two have a lot in common and map well together. Professor Richard Watt from UCL in this paper in 2007 talked about the fact that if we focus narrowly on downstream interventions, we are unlikely to make an impact on oral health inequalities. So if we focus merely on oral health education and clinical prevention, but that if we focused on upstream interventions, we're much more likely to have an impact on inequalities. But he did say it was important that we take action across the piece. So if we think about our downstream, or you could call service interventions, we think about the use of delivering better oral health. That tells us what the evidence says works in terms of service delivery for oral health improvement. And we can deliver programs such as Starting Well or other options that come through transformational commissioning. And Yorkshire and the Humber and Simon in particular have perhaps led the way around practice in prevention. And so I won't say anything more about that because I'm sure it will come up in the discussion. If we think about midstream interventions, training the wider workforce, there were comments in the chat about health visiting and how important they are. So really quite disheartening to hear about the disinvestment and the difficulties in terms of their delivery of oral health. Also early years staff, pharmacy staff, and community-based programs such as supervised toothbrushing and fluoride varnish. And then if we think about the upstream areas around food policy, sugar reformulation and the sugar levy, food advertising, we've talked about already, and water fluoridation legislation. And so this sort of downstream service level intervention, midstream community level intervention, and upstream civic level intervention maps really well onto this population intervention triangle model. We have evidence for oral health improvement. On the left, we have service level intervention evidence with both delivering better oral health that says what advice should be given and what preventive treatments, but also the NICE guidance that says how do you do it, which is just as important about changing behaviour. We also then have community level and civic level evidence, which is for children and for vulnerable older people. The community level interventions that are recommended by Public Health England, there were 9 that were recommended, and you can see them on the slide here. But they not only improve oral health, but have encouraging impacts on reducing oral health inequalities. With regard to water fluoridation, the Public Health England Health Monitoring Report adds further weight to the conclusions of previous reports that fluoridation narrows oral health inequalities in children.
So this is me on a Wednesday afternoon, every Wednesday, extracting multiple teeth under general anaesthetic. The numbers on the right, each one represents a tooth removed from a child. In the jar here, the now infamous jar of teeth, there are nearly 100 teeth removed in one afternoon in theatre, and it includes 20 teeth from 1 2-year-old child. So let's bring this back to the children, because we've talked a lot about the data, but actually this is something that is having an impact on tens of thousands of children every year. This week, I consented a 13-year-old for a clearance of his permanent dentition. Enough is enough. So I make no apologies for my passion or challenging the system or what we're doing now, because we can't carry on doing things in the same way in the future. So here are some of those facts. We've talked a little bit about general anaesthetic. We know that pre-COVID, every 10 minutes a child was having decayed teeth removed under general anaesthetic. It's the most common reason for a 5 to 9-year-old child to be admitted to a hospital. And wasn't it great to hear that Bola is on top of her game when it comes to oral health? This really matters. We know there is a significant cost to the family, to the child, to the parents, whether it's about pain, whether it's about sleep disturbance, time off school. But there's also a significant cost to the NHS, as Jenny pointed out, to the tune of around £50.5 million every year. And the frustrating thing is that this is for a disease which is almost always preventable. We know that there's inequalities. We've talked about them a lot today, but remember that children coming from lower income families are almost twice as likely to have decay. They're more likely to experience toothache. They're more likely to have difficulty finding an NHS dentist, and they're more likely to report that their poor oral health is impacting on their daily life. And there are inequalities by geographical region. My clinical practice is in the Northwest. We have 50% of children in Oldham starting school with visible decay. No one wants to be top of this leaderboard. And as I've said, and as Sir Michael said, it's not just building back, but not just building back better, it's also building back fairer. So to pick up a few of these, I have talked about accessing dental care. I would love to see supervised toothbrushing. There's been comments on this in the chat, in all early years settings. If I could, spend that money, then it would be all children in early years settings, so reception and nurseries, having access to supervised toothbrushing. But I'm really heartened to see some of our NHS regions commissioning these services for their high need areas. And this has certainly got to be more widespread. We've talked about that and community water fluoridation as part of a range of measures and recognised in the NHS menu of oral health interventions. We've talked a lot about oral health inequalities. We've talked about coding for referral lists. Bola has kindly included an oral health indicator in her dashboard, so it's just keeping oral health on other people's agenda. And what I mean here about a hyperlocal approach is similar to the conversation we've been having about vaccine. If we have good data and we really know where our high-risk children are, we can actually target our interventions very, very accurately, almost to the level of 2 to 3 streets distance. And for me, that is going to mean looking at the lessons that we've learned from the vaccine uptake programme. And for anyone interested, follow Dr. Helen Wall in Bolton. She's led the drive to increase vaccine uptake in Bolton hugely successfully. And she's done that by walking the streets, by community engagement, by working with community leaders, by working with faith leaders, by really understanding, not just guessing what the barriers might be, and then working to overcome them. And I think we from oral health have a lot to learn. I think that we need, as practitioners, those of you that are starting out in your career, have a look at when you have a child that is high risk, when you are referring a child to me for a general anaesthetic, is there any more you could be doing to support that child and their family? Because I would argue that as well as following all the guidance that we've got about reducing recall, about delivering chairside interventions, I would also like you to think wider than that. Is there a sibling? Is there a younger child sitting there with Ribena in their bottle that would also benefit from receiving this targeted approach? We need to think much more than just the patient in the chair. And as a member of Diversity and Dentistry Action Group, I think there's training we need to address as a profession. Some of our outcomes are related to unconscious bias that is inherent within our profession. We need to recognise it and address it. And I would like us to rephrase the term hard to reach. I think it's that we need to work harder to reach these families. It's not their fault. We need to help support them access care.
In terms of the population and community prevention, supervised toothbrushing has got really good evidence compared to a lot of other things that we do. And it has strong effect, and it is shown to be cost effective. The next issue next to that is how do you keep it to be cost effective in terms of who delivers it. And so there are different models, and a lot of these programmes have been delivered by local authority type funding. And as we've heard, I think several times earlier this afternoon, there have been shifts as to where the funding for these types of programmes have sat, and what's happened to those types of programmes reducing over time. The problem that you would have potentially in terms of transitional commissioning is there is only one size of budget, that we would be playing off against. And then we'd have to think about what are the opportunities cost to implementing that programme based in general practice. And so I think in terms of the strategy, particularly in using the supervised toothbrushing, I don't think that's up for debate, but how and who delivers the toothbrushing programme is something that needs a bit of thought, really. And I think it was Greg, particularly earlier on, sort of said, well, we are going to have to talk about funding and who delivers these types of programmes, because that's what's going to make these things happen.
Thank you.
If I can just add to what Rebecca has said, I think we're all in agreement about the evidence base, and it is one of the recommended interventions by Public Health England. The finance is a challenge. One other enabling factor at the moment is that oral health in schools is now a statutory requirement right through from early years, primary school and secondary school. So the early years are the particular focus around these types of interventions, but it's the sustainability of the financial model for it. The other thing I would just add is that there are different models. Some are funded through the voluntary sector, others are commissioned by local authorities, some are commissioned by the NHS. And that brings us back to the coordination and collaboration piece and how important it is to make sure these programs are getting to the right children and are sustainable. And, you know, it's really difficult. I can see that from listening to the difficulties in the public health budgets and local authority budgets. So yeah, very challenging, but very supportive.
Thank you, Jane.
Can I dive in as well, because I think that's very true. I think the other thing we need to look at is, we know something like supervised brushing has an evidence base behind it, but what we also need to work out is how that works going forward, so that we might find there are multiple ways of actually delivering this, and slight nuances in the way it's delivered, who delivers it, how it's delivered. And the main thing we've also got to concentrate on is when we put those into place, that we put in a robust service evaluation of it. So we gather the data to say exactly how was it delivered and what sort of improvement it made, because that's going to strengthen the ability to say that we need this collegiate collaborative working across where the budgets will come from and who will deliver it and how it will work, so that we make sure that that continues to improve. Because we're in the environment now where we're starting to change models, and we want to keep influencing that by actually proving that it works, and therein lies the major way that we can thrust these things forward. Thanks very much.
Thank you.
Yeah, I think Greg would say, and he's about to say it, Greg.
So yes is the obvious answer to the question. What's not to like? Two quick caveats. The budget for oral health promotion I've kept as high as I possibly can, but I've slashed it. We all want more prevention till it comes to paying for it. So we then all stare at the floor. Secondly, just a slight caveat and caution. I wouldn't argue against toothbrushing clubs for a minute. Just be careful of downstream drift. It's really, really easy to see and count the benefit of, well, no, actually, it's relatively easy to see and count the benefits of interventions that are applied at individual level. Much more difficult to see and count the benefits of interventions that are about shifting population context, aka community water fluoridation, but probably much more impactful. So it's not an either or, it's a both. So, and I think we'd be careful not to do only interventions we apply at individual level. Obvious parallel: smoking cessation services, helping smokers stop smoking. Spectacularly effective thing to do. It makes almost zero difference to population prevalence of tobacco. Things that do make a difference to population prevalence of tobacco: minimum age of sale and tax. And the same is in play here. So yes, obviously is the answer to the question, but with some caveats and some nuances.